I think pregnancy and pregnancy loss is a private matter to some extent, but no one should go through it alone. You don't have to post it on your bumper stickers or something, but I do think that you should make sure you're surrounded by people who you can trust and will care for you during this time.
Family building is supposed to be easy, and it can be a shock when it's not. The roller coaster ride of infertility can be a mix of emotions and conflicting advice along the way. As a reproductive endocrinologist and former fertility patient, I not only help patients build families every day, but I remember what the ride was like for me. Hang on tight as we learn together from experts and share stories from infertility warriors with compassion. I'm your host, Dr. Lora Shahine, and this is Baby or Bust. 1 in 4 pregnancies end in miscarriage. It's so much more common than we can realize. And without knowing how common it is, it can leave many people feeling confused, frustrated, and wondering what to do next. Here today to discuss all about miscarriage and recurrent pregnancy loss is Dr. Ruth Lathi, professor of obstetrics and gynecology and the director of the Multi-specialty Recurrent Pregnancy Loss Center at Stanford. Ruth, thank you so much for being here today. I'm really looking forward to this conversation.
I'm happy to be here.
I have dedicated so much of my patient care and learning and research to recurrent miscarriage because I learned so much when I was your fellow at Stanford. So when you're doing training, you have attendings that are teaching you a lot. And Dr. Lathi taught me everything I know because when I was at Stanford, you were opening up your multidisciplinary center for recurrent miscarriage. So I learned a lot while you were doing that. Why did you open up that center? What were your interests in that particular area?
When we started the multi-specialty recurrent pregnancy loss program at Stanford, we did this because we felt that our patients often didn't know where to go. They were spending a lot of time trying to figure out, should I see this kind of doctor or that kind of doctor? Do I need to see all the different specialties related to pregnancy, or is there one place that I can go? As we started to build our team, we realized there's about 9 or 10 specialties that all touch on the topic of pregnancy loss and repeat pregnancy loss. We felt that we didn't want our patients to feel that they had to navigate that. So we built a program where we collaborate, we meet regularly, we discuss our guidelines and our recommended testing. And honestly, there's about 20 of us now. Amongst the 20 of us, we decide when we need somebody to see a hematologist or a geneticist or a rheumatologist so that takes the guesswork out of it for our patients.
It's important for patients to realize who specializes in recurrent miscarriage. You know, there's so many different types of doctors out there. And I think people are going to their primary care doctor or they're going to their obstetrician and like looking for answers. But we are reproductive endocrinologists and really do specialize in first trimester miscarriage. And that's a little bit different from a perinatologist or a maternal fetal medicine doctor. Can you explain a little bit about the different specialties?
Honestly, this gets to the point of why we started our program, is that historically, recurrent miscarriage was thought to be a high-risk pregnancy complication or a high-risk pregnancy condition where they would see a maternal fetal specialist or a high-risk obstetrician. In reality, as reproductive endocrinologists, we are seeing people before pregnancy and in the very earliest stages of pregnancy. And this is really the critical time for setting up a pregnancy for success. We need to optimize health at the beginning of pregnancy, not after it's established or after we're already into trouble.
I have so many patients that have waited so long, searched for the right person to see, weren't sure if they even met the definition of recurrent miscarriage. When should people see a recurrent miscarriage specialist or a doctor like us?
We really leave it to the obstetricians when they are ready to refer because they've exhausted their level of expertise. On the other hand, if a patient or a family is feeling that their questions aren't getting answered, there is a lot to be learned from a second opinion, and that's what we're here for.
For so long, I was taught that someone met the definition of recurrent miscarriage when it was 3 miscarriages. And I think it's really important that that's what I learned in medical school. That's what I learned in my early training. And the American Society of Reproductive Medicine, which is our professional medical society, has said it's really reasonable to start an evaluation and start thinking about causes after 2 miscarriages. And I still have patients that are frustrated that they were asking questions and are told by their doctors that it has to be 3 in order to be referred.
I'm extremely grateful to our society for making that change in the recommendation. That's been pretty recent. And in fact, they took it even one step further to say that every pregnancy loss should be investigated. Doesn't mean that every pregnancy loss has to see a specialist, but a physician should think about every single pregnancy loss, even if it's the first one, to try to understand what the cause was, give the best explanation we know how to give to our patients so that they can be at peace and be ready to start trying again with confidence. You've taught me this, Lora, that really well-meaning words can be very harmful and painful. That, oh, this is for the best, you can try again. All these words that are meant to be helpful really are not conducive to healing and to respecting the experience that our patients are going through during the time. It's normal to be sad. It's okay to be sad. I would say it's almost abnormal not to be sad, to go through a miscarriage and just think or feel like, oh, well, that's not a normal response. The majority of our patients are extremely sad, and that sadness and grieving and healing can take weeks to months. I think, unfortunately, a lot of our patients are suffering in silence while their friends and relatives are trying to cheer them up, rather than just walking that path with them and allowing them to go through this very, very normal grieving process after a pregnancy loss. I think pregnancy loss at any time is difficult, but there's no rule that the further you are in pregnancy, the more difficult it is. I think early and late pregnancy losses are painful, and everybody will respond and grieve differently.
So how common is miscarriage? How do you explain that to patients?
It's the most common complication of pregnancy. We estimate that clinical pregnancy loss is about 1 in 5 pregnancies that are recognized by a patient end in miscarriage. However, when we start to look at our early pregnancy losses, those biochemical pregnancy losses, those really early losses that happen before a clinically recognized pregnancy, I would say it's much higher. Estimates are anywhere from 30 to 50% if we start to count those very early pregnancies and implantations.
The most common number I hear is like 1 in 4. 1 in 4 pregnancies will end in miscarriage, but it gets also a lot more common as people age, eggs and sperm. And so it can be as high as 1 in 2 pregnancies when someone's over 40. And I just don't think that we talk about that. We certainly did not learn that in health class growing up. It was you're so scared of conceiving when you aren't ready, so you're focused on contraception, and that doesn't finish the story, so that when you are ready to start your family, you're sort of imagining it's going to be easy, and that every positive pregnancy test next scene in the movie is delivering a baby. As doctors, weren't we always telling patients to, oh, well, don't tell anybody until after the first trimester?
You don't want to have to tell your family that you had a miscarriage. That assumes that our patients don't want to share that with their family. It actually encourages people to suffer alone and go through that loss alone. So I think pregnancy and pregnancy loss is a private matter to some extent, but no one should go through it alone. You don't have to post it on your bumper stickers or something, but I do think that you should make sure you're surrounded by people who you can trust and will care for you during this time.
I talk about now, because people will say, oh, well, when can I share? Like, when can I tell my friends and family? And I just sort of say, well, I mean, it's up to you, but maybe don't like post it on social media just yet, or think about who you're going to share it with, but definitely share it with people that you really care about and are close to.
It's a balancing act for sure. And we don't always get it exactly right. I think we have to be honest with our patients that there's no one right way or wrong way, that these are the reasons people might want to share. These are the reasons people might not want to share. And it's just that balancing some privacy around early events if you're not wanting to share. So it's always a balancing act. And I think we do our best, but we may not get it right every time. But we have to be forgiving of ourselves and those around us that we're trying.
I loved calling positive pregnancy tests. I'd always call and just be like, oh, I'm so excited. So amazing. And I called this woman and I remember dead silence on the other end of the line. I'm just going to make up a name. Sally, are you still there? I'm calling you with good news. And she's just sort of deep breath, sigh. Oh, Dr. Shahine, this is just the beginning. And that was such a learning experience for me. And I try to teach the team here, don't be surprised if you get a little bit of reserved reactions from some people that have been burned. And I think that's really important. It's like cautious optimism.
Yeah. And I think that that's a very normal reaction after a miscarriage, to have your anxiety level go up when you find out you're pregnant as opposed to go down. We see, both ways. And that's just because it's a natural neurologic phenomenon that we tend to repeat our histories in our heads. But it's very, very important for patients who've been through miscarriage to know that having another miscarriage is rare. Most people after a miscarriage will go on to have a successful pregnancy. And there are ways to kind of balance those emotions without fearing every pregnancy as it comes up.
I love the studies in our field that show that good supportive care through the first trimester from a clinic and providers, build your community, build your village, actually results in a higher live birth rate with the next pregnancy. And you can't totally explain it from just trying again. It's just I love that.
I know. I love that study too. I can't quite explain it other than just having that support system, someone to check in with, some reassurance along the way that things are going okay. So maybe there is something to that hands-on approach that we give in our clinics.
So what causes miscarriage?
Well, as you know, there are many, many causes of pregnancy loss. The most common cause of pregnancy loss in the first 3 months of pregnancies is a chromosome mismatch. That means extra or missing genetic material. That means that the embryo isn't healthy to continue developing. And so that takes up about half of all pregnancy losses, that one cause. These are random changes that occur in eggs and sperm as they're forming. It doesn't reflect that all of the eggs or the sperm will have that abnormality. It's a random or a chance occurrence in that egg or sperm, which is why most people who have one miscarriage or two often will, with the next pregnancy, be successful. But once you get past that 50% mark, and we look at that pie, there's a big piece of pie that's embryo genetics. And then there's a whole bunch of little tiny pieces of pie that involve all the other causes that we investigate as we start to look at patients who have repeated pregnancy loss to look for other causes. Unfortunately, still, a large percentage of patients who are having repeated miscarriage, they're not explained by our current testing. And that's probably one of the hardest pieces of what we do and what we continue to investigate through our research and other work. Yeah, there are many, many causes.
I always tell patients before we start the testing that the most common thing I'm going to say to them at the follow-up visit is that we didn't find an answer. So in general, what are the basic tests that you would order on someone who comes to you for recurrent miscarriage?
First and foremost, we'll spend a fair amount of the visit collecting the history. How did somebody get pregnant? What do we know about the details of the miscarriage? And was any testing done during the pregnancy that ended in miscarriage, such as chromosome testing or anything else that might give us a clue as to what happened during that pregnancy? In reality, the most important thing is to investigate the pregnancy and the miscarriage itself, as opposed to focusing on the prospective parents. The parents will be tested for genetic problems that could lead to miscarriage. Additionally, we want to really assess the health of both partners, the sperm and egg source, for other chronic medical conditions. Are there medications that might need to be optimized or changed that could result in higher rates of problems with sperm or eggs? So we really want to look at everything because I do believe that, especially in the setting of repeat pregnancy loss, there's never one single cause.
I love that you keep emphasizing, and I do the same thing with my patients, that the most common cause of miscarriage is within the embryo, and it's not the woman's fault. And women just carry around this incredible burden because they just assume that, of course, the embryo is perfect because they want this so badly, and everything plays into it. Our friends that are trying to comfort us will say, "Oh, what did you do wrong?" Or were you exercising too much? Or did you drink too much coffee? Or like they're trying to help as far as problem solve. But all of those questions are just leading into oh my gosh, I could have controlled this. I could have done something to avoid this incredible grief. And I just really appreciate the work that you've done to really show how much of this is an embryo issue. How do you tell your patients and kind of remind them? It's so easy to fall into that self-blame.
It's a really fine balance when patients are coming to us for advice. What should I do differently? What should I do next? To make sure that at the same time that we're investigating and we're talking about things that we could do different next time, that doesn't mean that a daily life exposure, a normal life, that was at all to blame for the pregnancy loss. We all know that there's so many different factors in our environment that interact. We only can control a very small portion of them. And so I focus on healthy lifestyle, minimizing exposures, but with a very, very large caveat that so much of this is out of our control. Most of my patients are already doing all of the right things. They are already doing everything that they were taught to do in terms of exercising and eating right and taking the best care of themselves that they can for their pregnancy. So it's a balance.
Everything in moderation. Yes, you should not drink alcohol every day, but a glass of wine once in a while, of course, or large amounts of caffeine have maybe been associated with early miscarriage. But can you imagine taking away a cup of coffee from people in Seattle? If people are such martyrs, if they are really eliminating everything that brings them joy, whether it's sugar or not even being able to plan a vacation because they might be pregnant, then they're going to not like life and maybe stop trying. With patients that are so vulnerable, looking for an answer, it's really nice to find a website that says, I'm sure it's your natural killer cells. I'm sure it's your body attacking your baby. And they use very inflammatory language. How do you navigate that with patients that really want an answer and they're I found this, will you do this test?
Yeah. There's a lot of stress and anxiety and emotion, obviously, around going through pregnancy loss, thinking about facing another pregnancy, wanting this sense of security that I'll do anything to have a healthy pregnancy. In reality, those of us who know the literature well and are being honest with our patients, we have to tell patients that we don't have all the answers. The allure of taking a medicine that is supposed to prevent pregnancy loss, I would love to have that medicine. If I could give my patients any sort of shot or pill or bed rest or I don't know, exercise, yoga, stand on your head, eat pineapples all day long. If I had that, I would for sure give it to a patient. But I think the honest truth is there's still a lot that is unexplained. And I think that the immune reaction to pregnancy is one of those. There really is no proven immune therapy right now for patients with pregnancy loss. So any of the treatments that are being offered are really unproven. Many of them have been studied in pretty large studies and shown to be no more effective than placebo or a sugar pill or a saline injection. What we're seeing is patients who are taking these medications and getting the same outcome that they would have gotten had they not taken that medication. And that's an important thing for patients to know. It's not that the story that their friend or their neighbor is telling, I took this medicine and now I have a baby. That very well could be true, but that doesn't mean that the medicine helped them have the baby. A lot of times I hear from patients or colleagues, what does it hurt to go see this immunologist? And what does it hurt to take these medicines? And I would say it contributes to the emotional exhaustion of the experience. It costs money. It has risks. And I really don't want to put a patient through something like that without any evidence or confidence that it will change their outcome.
I really appreciate how open you are to learning. So much of the time, I feel like it's very much like, oh, the Western doctors are the ones that are following evidence-based, are very anti or against the immunologists that are kind of doing a lot of this immune therapy. And it feels like an us versus them. And you're always so very balanced in explaining that, no, actually, there is evidence showing that these treatments have not improved pregnancy outcomes and live births. There are actually side effects to these, not only the cost and the exhaustion. I love that you brought that up.
If we're too focused on the immune system, we're going to miss something that we know how to treat already. And that's a proven treatment. We have a long way to go, but we're still doing pretty well. I would say that the vast majority of patients who see me, and I'm sure the vast majority who see you too as well, Lora, are having successes with the treatments that are proven. I think that that's really important to keep in mind, that as a patient, just the way that our brains work is that we think if we go through the same experience the same way multiple times, that we'll always get the same answer. And that's one of the great mysteries of repeat pregnancy loss. Why is it that somebody can have 3 miscarriages and then in her 4th pregnancy, they're going to have a success? And the reason for that is that every time an egg and a sperm join, there's a random combination of genes. There are thousands of things that have to go right in those first weeks before you even know you're pregnant that will set you up for success or failure in the pregnancy. Any sort of intervention later on is really kind of just cosmetic in most cases. So if you have a healthy pregnancy from the start, there's very little you can do to disrupt it. If you had an extra cup of coffee or a glass of wine here or there, that's not going to cause a healthy pregnancy to miscarry.
People often come to me looking to do IVF as a treatment for recurrent miscarriage because they know that the most common cause of miscarriage is a chromosome imbalance. They've even had miscarriages tested. And I do think that it helps some patients, but it's absolutely heartbreaking when someone goes through all of that work and transfers a tested embryo and they can still have a miscarriage.
There's a particular patient that it's right for, but it may not be right for everyone. If you've had a pregnancy loss that has an explanation, that is a chromosome abnormality in the miscarriage as the cause for the miscarriage, then that's an isolated event. That's that pregnancy. The next time you get pregnant, it's a different egg and different sperm. And in fact, most studies that have looked at it show that women with repeat pregnancy loss who have explanations, such as chromosome problems in their pregnancies, have a higher chance of success without treatment. We have to be really honest with our patients when they're making these decisions about treatment, because to your point, putting that much investment into a treatment and not having a success, I think adds to the stress of it. There's no simple answers. And I think that that's why, going back to one of the first things we talked about, was making sure you have time to talk to your doctor and that you have somebody that you can trust who answers your questions and explains everything.
You're always so incredibly positive about the recurrent miscarriage patient. And you always sort of help me feel like, you might not have the answers. You might not find that issue that you need to treat, but these patients are getting pregnant and each pregnancy is a new opportunity. A lot of people are nervous about taking care of a patient population where it's not black and white. It's not like blood pressure where you give a pill and make them better. And you just always give me those encouraging words. And I just can't thank you enough.
Well, in reality, most things in medicine are unexplained, even that blood pressure problem. Not everybody responds to the same medicines the same way. But yeah, I think, it's been a very exciting part of my career to be working with this patient population. There's just so many stories that we have, so many patients who have come to us ready to give up. I'm sure you have this experience too, where with some time and energy and knowledge and investigations were able to help them achieve their dreams of having a baby. And it's really, there's nothing better than that.
Thanks for being here today.
Thanks for inviting me.
Thank you so much for being here today. Every pregnancy is a new opportunity, and most people that are having miscarriages will go on to have the family they are trying to build. I'm your host, Dr. Lora Shahine, and this is Baby or Bust. If you like this episode, let us know. Give us a 5-star review and follow the show wherever you listen to podcasts. Baby or Bust is produced by Mark Ramsey, Jamie Solis, and Greg Moga. Executive produced by Paul Anderson, Nick Pinella, and Andrew Greenwood for Workhouse Media. Baby or Bust is a Mark Ramsey media production.